Assalamu alaikum. Today the topic is about larynx, that is laryngeal tumor neoplasm of the larynx. And before that, you must have an idea about the larynx, that it has three parts: supraglottic, glottis, and infraglottis. Supraglottis means above the vocal cord or glottis. Infraglottis, subglottis means that it is below the vocal cord. The glottis itself is vocal cord. So there are different types of neoplastic lesions, that is tumor, which have some risk factors. Risk factor means that they have carcinogenic factors that can result in laryngeal tumor. So laryngeal carcinomas are prevalent in heavy smokers, have a relatively early presentation, with the exceptions of supraglottic malignancies, which are likely to metastasize to regional lymph nodes. Because the laryngeal tumors, which we usually signifies that it is strongly confined to the vocal cords or glottis. No, it is not like that. Laryngeal carcinomas can be in supraglottic region or in subglottic region. So the glottic tumors are usually late presentation in association with the lymph node metastasis, because in glottic tumor it has a scanty lymphatic drainage. So in that connection, it has presentations are relatively late. But as we compare the supraglottic region, there are some other symptoms, signs and symptoms, which can be differentiated from the glottic tumors. Anyway, heavy smokers, smoking, cigarette smoking, alcohol consumptions, these both are strongly associated with laryngeal tumor. Tobacco is the most acknowledged risk factor. It is preventable if a person is stop smoking. It can be a bit reversible, that the condition of the laryngeal cancer, if it is in a very early stage, can be a bit conservative, can respond to conservative treatment. But if the patient continue the use of smoking, then it is difficult to stop the progressing disease, and it need at the end some surgical intervention which may be aggressive. So it has been studied that a person who take about a packet, 20 cigarettes per day, it has about 12 to 13 times higher risk than the non-smokers, and those who are in use of alcohol consumptions, they are at much more higher risk, that is about 34 times. And it can develop other head and neck cancers also. And at the end, the combination of alcohol and smoking, it can be a very aggressive, and the result is not additive, it is more than additive. Human papillomavirus has been detected in head and neck squamous cell CA, but the studies have not clearly confirmed it, but it has been detected or seen isolated from patients with CA, squamous cell carcinoma of larynx. The premalignant lesions and carcinoma in situ, that is a very earlier conditions that can be seen in patients which are in developing stage, developing conditions of the laryngeal cancers. The pathology of the squamous cell epithelium progressive. In the slide, you can see in 5 different categories, starting from the hyperkeratosis, which is just a very early stage. Then the hyperkeratosis with atypia, a bit changes. Then carcinoma in situ, that is involving a bit of basement membrane, and superficially microinvasive carcinoma, and then invasive carcinoma. The lesion which we can see in atypia or carcinoma in situ, this can be managed with a local excision. If the margins are clear and the excision is complete, the patient can be cured completely of the disease. But as it is progresses to superficially invasive carcinoma or invasive carcinoma, then with a minor surgical procedure, it couldn't be cured. If we come to a supraglottic cancers, in supraglottic cancer, while managing the primary tumor that is in the supraglottic region, the neck should be assessed, evaluated, because in it, as it is rich in lymphatic drainage, so there are more chances of neck metastasis, that is regional lymph node metastasis. So always in supraglottic cancer, we use to consider the neck as a part of the investigation. So it should not be ignored. In early supraglottic tumor, like epiglottic tumors in early stages, which are suprahyoid. Here again, suprahyoid and infrahyoid has a bit differentiation in the disease process. In early supraglottic tumor, which is suprahyoid, can be grossly excised endoscopically with Situ laser, carbon dioxide laser. And if it is excised, the patient can cure better and give good results as compared to infrahyoid, in which repeatedly laryngoscopy is needed and biopsy is the main part of the treatment. And if it extends to the pre-glottic space, it can involve about 50, which is involved usually in 50% of infrahyoid squamous cell carcinoma. Pre-epiglottic space are not invaded in suprahyoid tumors, but in infrahyoid, it is most commonly involved. So in such conditions, if infrahyoid tumor is seen, diagnosed, then endoscopic resection with neck dissection, neck evaluation, that is important, so that the lymph node in the neck should not be ignored. It should be surgically moved. So improved local control has been reported when post-operative radiation is included in the management. And for the post-operatively, if radiations are required, it is given, the patient can have better result. Glottic cancer. Squamous cell carcinoma of the glottis is usually well to moderately differentiated and present at an early stage. When we talk about the glottic tumor, it means that the tumor in the vocal cords are involved, glottis is involved. The glottis term is used for the vocal cords. If it is in the early stages, that is T1, T2, moderately differentiated, these tumors have rarely have regional metastasis. Regional metastasis means the regional lymph nodes. So in such cases, if the primary disease is treated, then there is no need for further surgeries or further like neck dissection. It is not needed. But luckily, the patient is diagnosed at T1 or T2 stages. Symptoms in glottic tumor usually of such condition originate with at the phonatory surface, that the surfaces which come in impaction while adduction of the vocal cords that approximated These surfaces of the vocal cords are usually involved because they are exposed to frictions. So these are the surfaces, phonatory surfaces that come in approximation with each other, the vocal cords. These are the more risky part of developing glottic tumors. And if the early diseases is managed with radiotherapy or conservative surgery without need of any elective neck management, as I've told you that there is no need of neck dissection in early tumors. If we are talking about the subglottic tumor, it is although a bit rarely seen in the laryngeal cancer, about 1% of the total. And it is the part subglottic. It is the part about 1 centimeter below the vocal folds. Vocal fold means the surface which come in approximation of the vocal cords, which come in approximation with each other. If we measure 1 centimeter below that towards the trachea, this is the part of the subglottis. So clinically presentation is usually airway obstruction. Definitely. So, and it is, this carcinoma is usually misdiagnosed and is taken for other low respiratory tract lesions in origin. So it must be investigated and evaluated that whether it is a pure confirmed subglottic lesion or it is some other conditions. So true subglottic lesions arise below the conus elasticus, as I have told you, that is 1 centimeter below the free edges of the true vocal cords. And it can spread locally to invade the cricoid cartilage. It depends upon its spread. It can spread to cricoid cartilage or thyroid gland. Lymphatic spread, if lymphatic spread is there are a few lymph nodes that can be involved. One is the lower deep jugular lymph nodes. Other is the pre-laryngeal and paratracheal lymph nodes. These are the lymph nodes which can be commonly involved if the subglottis tumor is there. Management usually requires a total laryngectomy because the invasion of the laryngeal framework is common if thyroid gland is involved, pretracheal regions are involved, thyroid cricoid cartilage is involved. So in such conditions, and there are chances that this disease can transmit, this disease can progress towards the glottic and even supraglottic region, glottic area. So in such cases, the larynx is almost involved more than one subside. So total laryngectomy is usually the treatment of choice. So if positive paratracheal nodes and extensive invasion requires, so post-operative radiotherapy must be included in the treatment modalities. And in such radiotherapy, because it is lower down, the subglottis is the area of lower down below the vocal cords, near to the mediastinum. So superior mediastinum must be in a range of radiotherapy to prevent stromal resection, stromal recurrence. Stromal recurrence is a point where we do a tracheostomy. Permanent tracheostomy, a tracheostome is made. So this is a stoma, and its recurrence is very common. Is properly not radiotherapy is given. Diagnosis depending upon which area, which part of the larynx is involved. Suppose any patient with hoarseness lasting longer than 4 weeks should be evaluated, right? Other symptoms like hemoptysis, halitosis, or somewhat hot potato voice means muffled voice. It is not a proper name, a muffled voice. A thorough laryngeal examination is essential. A thorough laryngeal examination is essential, and as we know, while examining a patient for a laryngeal lesions, we use ideal indirect laryngoscopy. This is we do in OPD. Further, if we need some examination very close or in depth, then we can do a flexible laryngoscope, or we can do in operation theater. DL means direct laryngoscopy. And direct laryngoscopy we usually use for the purpose of diagnosis and examination. We can take biopsy by means of that. So some investigations, some examinations are non-invasive. We not need any anesthesia like ideal or flexible laryngoscope. But in some, if we do DL, direct laryngoscopy, then we need to patient and to do give full general anesthesia to the patient. By that mean we can, it is both for the purpose of examination and for taking biopsy. If the patient is a gag reflex or local inert may prohibits complete examination, in particular the interior commissures are not properly visualized. Some supplemental examination is used, and that's one of the flexible endoscopic examination is one of that. Usually, if the there is some involvement of the upper esophageal region and piriform sinus get some pooling of saliva. So in that case, the saliva should be clear, the secretion should be clear, so that we can visualize and perform proper examination. Because clear visualization of the mucosa is mandatory, and so that we can be able to see the vocal cord mobility. And because the vocal cord mobility is one of the important site to be located, to be seen, so that we can have a proper staging and have a proper idea or decision about the management, to see whether the vocal cords are paralyzed or they are mobile. If they are paralyzed, we can also have an idea both of the vocal cords are paralyzed or one is paralyzed, in which position they are. And so further we can see and examine the piriform fossa, the pre-epiglottic space, base of tongue, all these regions, epiglottis. So the vocal cord mobility is one of the major site to be examined, and its condition and stage should be decided. Cancer of supraglottic larynx, as I told you before, have some paucity in the early symptoms because there is no hoarseness in supraglottic tumor, but dysphagia and otalgia or odynophagia may be the suspicion. So if a patient with prolonged dysphagia or otalgia or odynophagia with some neck swelling is seen, then the patient should be evaluated for any supraglottic lesions. And often such patients are previously treated medically. This is one of the problems sometimes the otolaryngologists face, that such patients are treated for, get some symptomatic treatment for dysphagia or otalgia or odynophagia. So if the patient with medically treated for these problems and didn't get relieved, then patient should be examined and should be evaluated both the larynx and the neck, so that to reach to a proper diagnosis and to decide further by a proper management. Airway obstruction with no apparent voice change, the presenting sign large supraglottic and subglottic lesions. If there is airway obstruction and voice change is not there, and the presenting signs, so the supraglottic or subglottic lesion may be expected, because if a large supraglottic lesion is there, the patient may have developed airway obstruction. But as vocal cords are spared, vocal cords are not involved, so the patient is not hoarse, right? Second, if the subglottic lesion is involved, what will happen? The subglottic lesion is, if there is subglottic lesion or subglottic space, subglottic area is affected, involved, there is some lesion of laryngeal tumor, and it has not extended to the glottis, that is not extended to the vocal cords. So the patient again will have airway obstruction, but not hoarseness. So this is the one thing that you can keep in mind in your differentials. Critical factor of evaluation of the laryngeal image, that is when we do a CT scan or MRI, what we want to see about the tumor size, what is the tumor volume, what is the tumor size, whether the cartilaginous invasion is there or not. Next, that the spread of the tumor, if it is glottic, whether it is extended to supraglottic or subglottic, or which subsite of the laryngeal tumor has involved, whether it is extended from one side to the other, or it is involved all the three, that is spread across the supraglottic, glottic, and subglottic boundaries. These are different boundaries starting from the supraglottic to subglottic. So it is important, it is mandatory that you must know about the tumor progression and involvement of the sub parts of the larynx. Next, the infiltration of the pre-epiglottic space, paraglottic space, and pharyngeal planes, and the neck nodes. So on taking images of, or prescribing, advising the MRI or CT scan, we have an idea in mind, and we want to evaluate and we want to see about the tumor size so that we can be able to stage the tumor, that is T. Cartilaginous invasion, so that we can further get an idea that whether it has got some complications. Next, its progression, which areas of the larynx is involved. It is confined to one part, or it is progressed to other adjacent parts. Next, whether it is extended to the pre-epiglottic space, paraglottic space, or pharyngeal region or not. And next is the metastasis, that is node, PK, TNM classification, tumor, node, and metastasis. And distant metastasis, that is for the M. So MRI offer greater sensitivity as compared to CT. So yes, usually we need a biopsy, and when we do DL, we have an aim that we can take a biopsy from the patient along with the examination. So several benign conditions. This is one important, is taking the biopsies that to confirm the diagnosis, because many other conditions like fungal laryngitis, sarcoidosis, tuberculosis of the larynx, Wagner granulomas, that are similar in appearance to the malignancies. So they can be confused with such condition on just examining the patient. So if there is some confusion about the confirmation, so it is better to take a biopsy. So biopsy will give a clear cut and 100% a pure and clear picture of the tumor, or if it is not tumor, then we can be get an idea whether this biopsy is confirmed and it is tumor, malignancy, laryngeal tumor or not, and can differentiate from other diseases. While taking the biopsy, there must be a sufficient tissue volume to ensure a correct diagnosis, because especially if when we take biopsy of the disease, so there must be a small volume, small area of the normal tissue, so that it can be diagnosed, can be differentiated. If this tumor is very small, then it is better to excise this completely with a minimal, limited, healthy laryngeal mucosa, so that we can know about the depth of the invasions, that the how much in depth this tumor has been extended beyond the superficial lesion which we are biopsying, or which we are seeing at that moment. Staging is important. TNM classification: tumor, node, and metastasis. T for tumor, N for nodal lymph node metastasis, regional lymph node metastasis, and M for the distant metastasis. So this is the TNM classification which you will come across in tumor whenever you study the tumor. It is necessary, one, for the patient discussion, that you can discuss the disease with the patient or his or her relatives, so that you can give them a clear picture of patient diseases. And the next, that you have to decide that to which extent you have to go now, what is your treatment modalities, whether it is just a conservative treatment or it needs some minor surgery or some aggressive surgery, or both surgery combined with radiotherapy or chemotherapy. So depending upon the stage of the patient, you have to decide. Next, the goal of the therapy is the eradication of the cancer. Why we do such therapies? We do such therapies, whether surgery, radiotherapy, chemotherapy, whatever, to eradicate the cancer, to clear the disease. So the patient usually adopt a lifestyle modification resulting from the treatment sequelae. Secondary objective include, we are talking about the larynx, that is voice quality, that is preservation of voice and swallowing, because it is at the nearby area of the esophagus, upper esophagus. So we have these three aims or goals while treating a patient with laryngeal lesions or tumor. For 90% of the laryngeal cancer is often squamous cell type. So it is a very large percentage. And the important tumor parameters, what are the important tumor parameters by means of which we can have an idea? That is, we have discussed already, that is the vocal cord mobility, anterior commissure involvement, and depth of the cord invasion. Tumor location is again important, whether it is a glottic, supraglottic, or subglottic. If the tumor is exophytic tumor, it tends to respond better to radiation as compared to the endophytic, and prognosis is better a bit. Next, the degree of differentiation has been correlated with the metastatic potential. So poorly differentiated tumors, as you know, as you studied in your pathology, poorly differentiated tumors are more aggressive. There are different surgical treatment choice depending upon, it is not confined to, depending upon the TNM classification, TNM staging of the patient. Surgical treatment is always dependent on the TNM staging. So the choice of surgical approach depends upon the tumor size and location. For early laryngeal tumor, we just do a partial procedures, endoscopic surgery. With advanced stages diseases, if the surgery is chosen, then the treatment is total laryngectomy. Partial laryngectomies are also done with horizontal, vertical, cortectomy. These are different procedures which we do in select patient. But in advanced region, removal of the primary tumor must be accompanied with neck dissection. Again, TNM staging. If the primary tumor has involved also the regional lymph nodes, so definitely while excising the primary tumor of the larynx, neck dissection neck nodes are also assessed so that further recurrence may not occur. The primary advantage of sometimes we give preoperative radiotherapy, and the operative radiotherapy have advantage because the tissue is already oxygenated, and unoperated tissues of tumors are definitely have oxygenated tissue, and it has better vascular supply. So radiotherapy can be effective in such unoperated cases compared to operative. Post-operative radiation have its own advantage and a significant improvement in the lymph node control with both operative versus preoperative radiotherapy. So these have their own advantages. Thank you.